the onus is on us as providers to state where the value is in continuing this treatment, especially when it comes to the chronic pain workers' comp population.
Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello again. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar with Rehab Practice Solutions. And we are approaching the end of the year. It is December, mid-December of 2023. And if you are organizing an event, you're looking at putting together speakers, you're gathering your lists and all that, the calendar is getting opened up for this coming year. So I figured I'd put the plug in. You can go to, if you want to book me to speak, you can go to speaking.rafisalazar.com, learn everything about there. I am doing a few events already in Q1 and Q2 of 2024 that I'm excited about. More to follow on that if you follow me on LinkedIn. But you can head over there, read a little bit about my bio, read about the book, Better Outcomes, A Guide to Humanizing Healthcare. My goal is to help you and your organization or your audience receive the tools and insight necessary to help you humanize healthcare, to make healthcare human again. So if that is interesting to you or something you're looking at putting together in 2024, trying to round out some speakers, head on over to speaking.rafisalazar.com. Alrighty, and if you are looking to explore and understand a little bit about insurance denials, maybe peer-to-peer review issues with your documentation, this episode is going to be hopefully insightful and of value to you. This week, I'm speaking with a physical therapist. Her name is Johanna Metzger. She is the CEO of the Nourished Nest PT, but what she has also done for the last 7 or 8 years of her career is she has worked as a insurance reviewer, a documentation reviewer, and she has a lot of experience specifically in the commercial and the Medicare Advantage space and the occupational health space, looking over notes and documentation from rehab clinicians and helping tease out what is valuable in that note, in that documentation, and what is not. So when I was going through school, this was 11, 12 years ago, you probably were told this too, going through school, like, you need to document everything, you're covering your own butt, you're trying to prevent, litigation, and then you're also trying to quote unquote justify services. And what ends up happening, I've noticed this a lot with students that come through the clinic. I've noticed this a lot when I'm reviewing. I do some lectures every now and then and some presentations and seminars at the university, at the OT program here. And I will do whatever it is. We're doing a case study. We're talking about maybe shoulder dysfunction or upper extremity dysfunction. And part of that seminar involves, okay, let's write this documentation up. Let's write an eval or a note or something. And the amount of extraneous stuff that gets put in this note is quite baffling. And a lot of times it's because, as students and as clinicians even, we're told you need if you didn't document it, it didn't exist or it didn't happen. And you want to make sure that, again, you're crossing your T's and dotting your I's. You're preventing litigation, really, is what it looks like. We're trying to put so much in there that we can't, we didn't forget anything. We didn't miss anything. But what we need to understand is that depending on who is paying for the services, we talk a lot about this in positioning and marketing strategy for some of the healthcare technology companies that I work with, the innovative healthcare companies. Like, there are 4 stakeholders in healthcare. There's the payer, there's the provider, there's the policymaker, and then there's the patient. And depending on who is paying for the services or who the documentation is really geared towards, should really drive some of those things that are highlighted in the note, because each of those stakeholders view things and they are looking for different things in the documentation. So this conversation with Johanna is really talking and focusing on what are insurance companies looking for, those payers, those third-party payers. What do they want to see in a note? What information is important for them to help make the decision of, are we going to continue to pay for these services? Because that tends to be where a lot of those requests for authorization or continued authorization are denied, or requests for more visits, or whatever the case is. I'm sure if you run a clinic of some kind, or you're involved in clinical care, and some of your payers are these MCOs, these managed care organizations, you've undoubtedly run into needing to do a peer-to-peer review call with a reviewer from that insurance company, or you're submitting documentation hoping to get more visits for a patient that might legitimately need it. And oftentimes, it's not that there isn't enough information in the documentation, it's just that it's not the right kind of information, or the information is not presented in the way that the insurance company, who's the ultimate, I mean, call it what you want, they're the ultimate customer of this service here. They want information a certain way to make decisions, and even if you have the right information, it's just not presented correctly, or it's not in the right, it's not facing the customer, who's the ultimate decision maker, then you end up losing out on those visits anyways, or you don't get approval, or that you get a denial, or whatever it is. So Johanna shares a lot of information about. We have a little conversation about her shift from clinical work to utilization review and insurance review and that, but then the bulk of the discussion is all around what needs to be in the note. How do we need to think about our documentation as clinicians? Hopefully you find this, like I said, very insightful. It's one thing, I know I handle this all the time at the clinic that I own and operate. Somebody's got a peer review with Blue Cross, or with Cohere, or some kind of managed care organization, and there is a lot of emotion on the side of the clinicians. They're saying, okay, they just want to deny this service, and Miss Smith or Mr. Jones, or whoever it is, really needs continued therapy in order to get better, or whatever. And without having the right documentation, or the right information in the documentation, those visits get denied, or the authorization gets denied, and it's very easy for the clinicians to get angry and upset. I mean, justifiably so, right? You want the patient to get services, and they're getting denied. So Johanna shares a lot of useful tidbits about how to make sure that you can decrease the risk of that happening to you and your organization. So without further ado, here's Johanna talking about insurance review, denials, and documentation. Well, hey, Johanna, welcome to the show. How are you?
Good. And how are you?
I am doing all right. I'm excited about diving into insurance denials, specifically as they relate to physical and occupational therapy. Before we dive too deep, just tell us a little bit about yourself, your experience, and what brought you to what you're doing now.
Sure. Thanks for that. So I have been a physical therapist for 21 going on 22 years, back in the good old days where all you needed was a bachelor's. So going in the early 2000s, you just had a different landscape as far as clinical treatment, where you were seeing patients 3 times a week. You could write your assessment, tolerated treatment well, and continue plan of care. And that was 50% of the SOAP note, and it was just fine. With the advancement of HMOs and just cost containment, that definitely changed as to what we know PT to be today. I spent the majority of my early career in outpatient orthopedics, some neuro, and I got into occupational health, industrial rehab, workers' compensation. And I am bilingual, speaking Spanish and English. At the time, I was in Washington, D.C., and then moved to Chicago, where I managed a series of clinics that we did work conditioning, work hardening, functional capacity evaluations, and chronic pain management. Really working in that multidisciplinary approach, I got a taste of how important your documentation and being very specific as to why you're saying what you're saying, because someone is actually reading it and making decisions. I think when we view our documentation as one way, like unidirectional communication or unidirectional platform, we just kind of get lazy and say whatever we think because no one's really going to read it, right? So through that, becoming a quality advisor in a workers' compensation role, in my last role in workers' compensation, I was an area mentor where I would go into clinics and cherry pick work comp charts and just kind of give therapists that very constructive, actionable feedback on, you're seeing this patient, you've seen them for 60 to 70 visits. How are you moving the needle? Help unpack that for me. So no one likes to be called out necessarily, because we as therapists may get defensive, but really kind of holding a mirror up to those clinicians and saying, hey, I know that your skills are valuable. You know your skills are valuable. But if you're asking someone to spend resources on it, the onus is on us as providers to state where the value is in continuing this treatment, especially when it comes to the chronic pain workers' comp population. And that really kind of lit a fire under me to document better myself. And when you're doing a workers' comp note, especially when you're iterating material and non-material handling, you need to be saying what you're seeing with that floor to waist lift, that waist to shoulder lift, what compensations are you seeing? And from that can justify, hey, this person needs more scapular strengthening because this is what I saw. So it was very easy. And I think every therapist should be a work comp therapist because it makes you document better. So from that really kind of lit a fire under me. And about 7 years ago, we relocated from Chicago to Charlotte. And I was just looking for a job, like any job that wasn't full-time clinic treatment, right? Pay me. I know things. So I do know things. I'm kind of smart. So from that, I came across an opportunity with a major third-party administrative company to do clinical review. And it was 100% remote, a complete 180 from what I was doing, driving everywhere. So that was a little bit of shell shock, but my husband and I moved, we bought a house, we did all the things and had a Suburban. Now we got a yard with a dog. Great. What do we do? So that really kind of opened my eyes to now, and I've been on peer-to-peer calls, and you get the angry fist, the shaking angry fist, old man, get off my lawn kind of thing. But now having 7 years later, having been on the other side of that. So basically for the last 7 years, I was doing clinical reviews for Medicare, Medicaid, and commercial insurance companies. And through that, just really reading on a daily basis, just crap documentation, superfluous information, where you kind of want to call the therapist and say, what were you exactly trying to tell me? Because you generated a document that's saying a whole lot of nothing, or it's a whole lot of too much of what we don't need and not enough of what we do need. And then there are times you get on a peer-to-peer call and you would be on with a very angry provider. And my mother, my abuela, taught me one thing, right? She said, you have to separate the issue from the emotion.
Yeah.
And I think as providers, you just get too caught in the emotion, and I get it. That's another soapbox, but I know you asked me about my intro. So finishing that up, and we'll get to that. So 7 years as a clinical reviewer. During that time, I had struggles with fertility and that's a whole separate other issue, but, pregnant, had my son, by IVF. And through that found like, oh crap, there's really gaps in women's health. My own firsthand experience. They tried to induce me to have a C-section. I said, no, that's not what I need. So through that, I, about 5 years ago, got into pelvic floor physical therapy, got my certification through evidence in motion, started treating up until COVID. That shut that down. So I have gotten that, finally got my doctorate. So I'm with the rest of the
congratulations.
Cool kids. Just like whatever. And I became a lactation consultant. So on the side, I do work with women virtually and families virtually on that, but kind of dialing into what the meat and potatoes of why we're here today. Through the last 7 years, you just get fatigued of not being able to help providers and share actionable feedback to them of what we need. And I think so many times as we're always worried about covering our asses. I don't know if I can say that on here, but I just did.
You can.
We're always worried. We're worried about mitigating exposure.
Yeah, liability and risk, right?
And I understand that, but all these social media groups we see that clinicians are in, well, I can't say this, and it's like, but if what you're saying is valuable and it's not, if it's inflammatory to a point it needs to be, to communicate a point, then it needs to be said. Of course, it needs to be constructive and supported with you know, don't just say this patient is awful and okay, why are they not a candidate for therapy? Because, they're worried about the Jim over Sebelius lawsuit and getting cut off. And you know what? I've been in this profession 22 years. I've done plenty of Medicare audits, plenty of Medicare treatment. No one has come to knock on my door, but I have been deposed 7 times. And I will tell you, that's not a fun way to live. But having been deposed 7 times for workers' comp cases, the zoom out for clinicians is when you document, and it is a habit for you, and you establish those good documentation habits, then you can't question when you get questioned on your process, when you get deposed or you get a Medicare audit, lean into the good clinical habits and skills that you have developed, and it won't steer you wrong. And that's not saying but that's not licensed to become lazy.
Yeah.
So all that is to say, my fire in my belly, aside from the women's health component, which is there, my fire in my belly is to give PTs, OT, speech, out any provider who takes insurance, very clear-cut, actionable feedback on what insurance companies look for, maybe the pitfalls that you fall into. I'm not saying you avoid insurance denials altogether, because there are times that providers are just treating just gratuitously and unnecessarily. And that's another thing we need to keep in check. But that you just understand from the clinical reviewer side what I see, what I look for, what we look for, so that you have that as a mirror to say, great. And now I take a look at how I document and how can I be more efficient, better, and kind of cut the crap. So that answers.
Yeah, I think that's a discussion we've had around the PTOT industry for a while. Like, we document a lot of stuff that doesn't need to be in there. So before we dive too deep into the disconnect, which we're talking about happening here between what insurance companies want or what they're looking for and what clinicians end up putting in the note, I guess the transition that you've been on the clinical side and you've been on the reviewer side. So as a clinical, a reviewer or a peer-to-peer reviewer on the insurance side, looking at another clinician's documentation, what are those things that you're looking for? Because, I own a PT clinic. I've worked in the space for a while. Like, whenever there's a peer-to-peer review coming up, either the admin team or the clinicians, they're just looking for stuff to deny. So, and obviously the people that are reviewing documentations aren't just looking, at least if it's an ethical company, aren't looking just to simply deny services to deny services. They're looking for a specific set of things. So as a reviewer, kind of what are the big things you're looking for to say, okay, this justifies, more treatment, or really this treatment isn't necessary? Are there guidelines or a framework, or is it an algorithm? Like, how does that work on the reviewer side? And then we'll dive into the disconnect.
Sure. So I think it's a both and. I think that some companies will use an algorithm with cursory information where you can input it on a web portal and it may give you a nominal amount of visits.
Yeah.
As far as it being a human reviewer, we're looking at, yes, age, diagnosis, comorbidities, and kind of that demographic information, but the why. Why are you treating this patient? From your subjective and objective assessment, what are the impairments that you're treating? And what are the resultant functional losses that you're treating? And as the episode of care goes on, what benchmarks are you evaluating and reevaluating that either show progress, stagnation, or sometimes regression? And what are the quantitative and sometimes qualitative, but the quantitative benchmarks that you're using that show that, hey, this person is showing benefit from the result as a result of my skilled care? And if they are not progressing, what are those barriers to progress, and why only skilled care can help to address them? I think that therapists misconstrue. There's no question people will benefit from stepping into a space, being served, so to speak, have hands-on, having that listening and validating ear. We can all agree that that is of benefit.
Yeah, that's helpful.
But when is that benefit really marginally or no different than implementing what you have done for them and kind of taking the ball and dribbling it and running down the field, whatever sports analogy you want to take with that? So,
yeah, like at what point does them coming in to see a clinician every week or every other week provide marginal returns compared to, okay, they've been given the skills, the tools, whatever,
Right.
the exercises, and they can manage it on their own. Like what is the breaking point there?
Right. And I think in an insurance-based setting, which is different from like I own a cash practice, that is a full disclosure. But still, when patients take super bills to their I'm an out-of-network provider and they take them, I still have to meet the same criteria for the insurance company to consider that. Now, it's the patient problem at that point because I have my reimbursement, right? But to be very clear about the why. So for instance, this analogy, I don't ever like to compare human bodies to inanimate objects, but if you go and get a quote for some service that you need done, you're going to want to know, and you say, hey, like I had my air ducts cleaned yesterday. They gave me a quote and line item each item, right? If they were just to say to clean a whole house air duct, it's going to be $2,000. To not get curious around the why and
Exactly.
the
Why are you charging
value,
me that much?
right, then you must have more money than Bezos. And God bless you. But I think that we need to have that same, because at the end of the day, healthcare is a business.
Yeah.
And we as providers have to stay profitable. Insurance companies need to, everybody is, it really, unfortunately, all is about the bottom line. So we do have to show value for what we are doing and why that value needs, it's important, right? If it were only the patient that needed to see the value, then it would be, we may be speaking a different set of criteria or value points or pain points to them than an insurance carrier. So as far as the criteria that we look for, number one, I wanted the why. What are you treating? And I'm going to say this, that pain is not a direct impairment. I will die on that hill. Pain is kind of it latches on like a barnacle to different impairments, or it may impede different impairments.
Yeah,
but
it's a secondary condition.
Right. It's not.
Yeah.
You know, we're talking range of motion, strength, balance, lack of proprioception, you know, those things that through our just special testing and all that crap that we do, that's what we uncover. And then from that, because of those impairments, what is the patient not able to do? They don't have eccentric quad strength. We know that's going to impact their sit to stand, getting up and out of a toilet, you know, putting on a pair of pants without sitting down, things that are mundane, but yet may be applicable. So when I'm on the phone with a provider, you know, the one pitfall, it's a frustration that I have, is that we're kind of, unfortunately, we can't really ask open-ended questions. That unfortunately at times is discouraged. But for me, if I were sitting and wanting to know more about it, and I'm the gatekeeper between you and more visits, then I would want to know, please tell me what is going on with this patient. I'd want to ask targeted questions. But sometimes we as reviewers can be hindered because we can't be perceived as directing care or, you know, we really have to leave it on that provider end to like, please let me know beyond what you've already submitted, what is going on with this patient, or in your eyes, what are the barriers to progress, or what are you seeing? So really you as the provider, knowing those key points of the why of what you're treating and what are those benchmarks that you are capturing and reassessing. You know, I can't tell you how many times where a patient or provider says to me, yeah, well, they don't have great balance and they don't have great, you know, their gait is off. And I say, great. Have you done a Berg-Tonetti, you know, timed up and go? Have you done their gait speed or 2-minute walk test? Well, no, that sounds like a good idea. And I literally want to reach through the phone and say,
somebody,
and choke somebody. Like who let you graduate PT school and not, this is like PT 101. Why are we not doing that? And I don't know where.
Or maybe they did it and they didn't document it, right? Like, oh yeah, we did it kind of, we screened them as they walked in, but we didn't really document it down in the eval. It's like, why not do that?
Right. And I will say, back to doing a functional capacity evaluation, I assess sitting tolerance when the patient's in the waiting room. I purposely had my desk where I could see where the patients would park and watch them walk in, because sometimes the way they walk from their car to the door was different than from the door to the chair. And I was curious about that. So you're always collecting that data, and just know that the data doesn't have to be confined. Another point I will make is that performance-based functional outcome measures like a Berg, a Tonetti, a timed up and go, a 5-time sit to stand, 6-minute walk test or 2-minute walk test, a 3-minute step test. All of those are very easy to render, you can gather so much information from it, and you can, it's research backed and all that kind of stuff, but it's so easy to assess and then reassess. I don't
Yeah.
need every single assessment tool in the world. Because another thing I hear from providers, well, I spend every other note reassessing. It's like, well, pick a cursory amount of things, reassess, provide the data. But I don't give me a Berg on the eval, then a Tenetti at 30 days, then try to keep that consistency so we
Yeah, so
can
you can
see
see
progress.
progress. Yeah, yeah. I want to back up because you just
Sure.
shared a whole bunch of value there. But backing up to what you said, kind of near the beginning of that, you said, okay, so healthcare is a business. We got to make the bottom line work. And then you did say something that I want to highlight. You said, well, if I was having this conversation with a patient about the value and what we're going to provide and all that, I might say something differently than what I say for insurance companies. I think that's something very, very important to highlight is that a lot of times as clinicians, we tend to see and I might get in trouble for saying this, but we tend to see our customer as the patient. But in an insurance based model or workman's comp or something like that, really the customers who's paying for the service, right? And in that case, it's going to be the insurance company in a lot of ways. I mean, sure, the patient might have a copay or they might be paying some kind of co-insurance, but the one of the big stakeholders that we tend to forget, we look at them as an enemy almost, but they are funding the service, is that insurance provider. And I think just that having that disconnect there, like you said, kind of the way we document is going to be a little differently, or the way we explain value needs to be focused towards that audience. And when we're writing a note, a lot of times it's for the payer, and the payer needs to understand what's important, what's valuable, and not necessarily the patient, right?
Correct. Absolutely. Absolutely. And I think that you may have the same assessment, but how you're pitching it to an insurance payer versus a patient is going to be different. It's always that any business coach will tell you, you sell the vacation, not the plane ticket. You sell
Yeah.
the good night's sleep, not the mattress. So communicating the optimal result of what your service can go, what you're getting towards, whether it's a reduction in fall risk because I'm implementing these interventions to work on this impairment that I quantified by this functional outcome score. The patient just wants to be able to walk across the street and not worry about falling so they can, if they're in an urban area. That's what's important to them. And you're going to say that same, communicate that, package that same statement in a different way to the insurance carrier. But, the biggest thing that people get frustrated about is ADLs. Now,
Yeah.
most commercial insurance companies are going to follow Medicare guidelines. And Medicare, I can pull up the compliance rules, but in the benefit policy manual, more or less says if it's not related to an activity of daily living, it's not under our purview. Meaning that if the patient is at a community dwelling level of function, I'm Medicare. I don't give a rip if they can golf or not. I don't give a rip if they can hike. And to me, that is, I get it. But on the other hand, that kind of feeds into the whole, we're not helping patients and enabling them, which we are the best people leverage to do it, to get more on the wellness side of things versus just hiring a trainer on social media, which I'll save that for another time.
Yeah.
But that is the Medicare guideline. So I will try to tease out on a peer-to-peer or anytime I'm in front of that audience. Please help me understand on an ADL level, is there anything your patient struggles with? So they may concurrently struggle with being able to hike or what have you. But if they also have difficulty going up and down a lot of stairs because they live in a third row or third level flat, great. That justifies the use of skilled care. So, understand that we as insurance reviewers are not the enemy. We are arbiters of the rules that either your health plan has in place or Medicare has in place.
Yeah. Yeah.
And kind of is what it is.
Well, and I think there's that whole fact too that a lot of clinicians and patients too believe that insurance should pay for everything, right? Like, oh, the insurance should pay for it. I'm having pain, yada yada yada. But I think there was an example like Aetna commercial or something like that doesn't reimburse for sports medicine, physical therapy. Like if you have an orthopedic surgery, they'll pay for that. But if you tweak your shoulder throwing a baseball, at least back in 2021 or something like that, when we were looking at the rules, like they weren't going to pay for that. And I know clinicians are like, well, oh my gosh, why not? And there isn't this the shift in the mindset should be like, okay, well, this now just becomes a wellness service that we're providing that maybe we pay cash, we charge cash for. It's a totally different thing. It's not medically necessary, quote unquote, according to the insurance company, but we know there's value there, and we know that
Right.
we're going to provide an improved quality of life. I think clinicians sometimes see it like, oh, if insurance doesn't pay for it, then they're saying it's not valuable. And that's not what that means. What it means is that the insurance is targeting a very specific area of
Right.
function or functional performance. And just because
Right.
they're not going to pay for, treatment A doesn't mean they don't think it's valuable. It's just not what they're covering, right? And I think that needs to be part of the discussion as well. Like, okay, just because it's not covered doesn't mean that we're saying it's not valuable. It just means that your patient is responsible for the cost, right?
Right. Right. And I think that kind of factors into, there's a meme that insurance is all about paying a lot of money to get sick or get hurt and to pay a whole bunch more money. And nothing could be closer to the truth, right? That unless you have, a pregnancy, it's kind of, we joked about this with moms who have babies, right? Once you've met that deductible and out-of-pocket max, anything you need done for the rest of the year, you do all the things, right? I had 2 orthopedic surgeries the same year I had my son. So I just got it all done because it was paid for. But you're right in that it's just the reality of what we need. But I think that you kind of can crap in one hand and wish in the other and see what piles up first. That, yes, I wish that an insurance company would latch more onto the preventative, the wellness type things. And I think you're starting to see that with some incentives. But, for instance, when I was working for an insurance company, we were basically self-insured, and they would offer up to 8 virtual physical therapy visits that you could use for whatever you wanted, which I thought was kind of cool. I mean, I'm a PT, so I don't use it, but all the other people who work for that company that didn't, that's a nice service that they're providing. So there may be within the employer benefit package stuff that your company offers. But for instance, there are certain things that should be just standard of care. Anyone who has a wellness, like at a certain age, why don't you go see a physical therapist to kind of look at overall movement? And that would be a nice way maybe to get that stream of referrals, not just wait until someone they fracture a patella or they get an ACL reconstruction or have a wrist injury or what have you. But I think that's kind of zooming out and where are the gaps in our healthcare system, which that's like 10,000 bajillion podcast episodes. But as far as, that you're stating, again, I will say it 10,000 times, but being very, very clear on your why for treating the patient. And I think back to your point, the why of treating the patient, you're kind of coding it, phrasing it differently for that insurance company, but also being very key to the patient of listening to what their goals are and kind of learning to reverse engineer or distill that into, hey, I'm not able to, for a lot of my patients, I'm not able to pee without, I can't start a urine stream without straining. That's a big deal to them. So I have to code that and to say, okay, what may be going on and I'm compiling that with my internal external assessment to the payer. But that's a goal for them, right? So a goal, if you're in a sports situation, could be, I want to be able to play soccer, run and cut and jump, without feeling instability in my knee. Great. You have your subjective objective assessment, and now you're filtering that and communicating that to your payer. So I think that, and you're being able to clearly state it. It kind of all filters down. The SOAP model is just, it's old as heck, but it just, it's old as heck, but it's like, it works.
Yeah.
It works. And being, again, cognizant, clearly stating your objective information, be cognizant and intentional about your wording. Use functional outcome tools that are appropriate to your patient. What I get on the phone that, most commercial or most TPAs or your third-party administrators may have a cursory number of what I call the cardinal outcomes tools. So your NDI, ODI, Quick Dash, and your LEFS. You know what? You are not contained. For the mic people on the mic at the end of the other microphone, you are not contained to only those 4 outcomes tools. There's so many, there's an inordinate amount. Rehabmeasures.org, which is funded by the Shirley Ryan Ability Lab out of Chicago. They have, if you have a diagnosis or a patient population that you want to assess, just search the database. They have so many good outcomes tools that I have come across. The functional independence measure, the PFDI and the POPD are specific to my population, but so many good ones that are just focus on your situation. Yes, the LEFS to me is useless if you're talking about someone in their 70s who had a hip replacement. They're not running 3 blocks. They're not doing that. That's not on their bingo card for the day. So you pick what does matter. Gait speed. That's not going to matter to a 16-year-old, but it is going to matter to somebody maybe in their 60s, 70s. So again, that you're using the functional outcomes tools that are appropriate to your patient. Don't use the excuse that whatever's on the sheet is all I can provide. Because I'm telling you, I'm giving you the permission you don't need. If you want to say they walk in the clinic, their step length is this, and it took them this long to walk this distance, great. Or one thing I used to do when I worked skilled nursing, I used to watch somebody get up off the toilet. They had shorts on or, underwear, whatever. I wanted to watch them pull their pants back up. They just had a knee replacement. So how are they able to do that? That mundane task, being able to time it and watch it and comment on it, then time 2 weeks or what have you, I time it, I watch it, and I comment on it to be able to say, you know what? This person is able to do that. And I think those little mundane things we overlook, but kind of zooming in, that's what's relevant to our patient. So all that is to say that the performance-based functional outcomes tools, of which the 4 that I mentioned are not, they're data points. But on top of that, watch somebody, what they do. Watch them, what they do. Can I time it? Can I quantify or qualitatively describe certain things about how they're doing it succinctly? And then I watch them do that same thing, taking off and putting on their shoes. So it's just thinking outside the box of what I can do to capture for that reader, the insurance company reviewer, how the patient's doing. Because all the fun stuff that we do and all the interventions and the Ultra G treadmill and all the good fun stuff, that's great. But it also incurs a lot of costs, a lot of flash. What results is it yielding? I argue, and what, my next venture is that when I have a patient, the virtual patients I see, what they need is themselves and a floor. I try to minimize the equipment they need because that's another barrier to replicating this outside of the house or outside of the clinic. So and avoiding the fluff. I think that there is a certain EMR system. I don't know if it's, WebPT or what have, and I love WebPT. I love those EMR systems because I think they kind of corral the cats, so to speak.
Yeah.
But the situation is evolving with changing characteristics. It's just some BS statement that's there. I'm like, why is this there? It says nothing. Yeah. So again, reading your statements, what is this saying? And if it's not saying anything, take it out. Okay. I'll pause and I'll let you ask.
No, that's good. I think, again, like a point too is the idea of like reducing costs. I don't think clinicians, we might be a little bit cognizant of it for patients, especially if they have a copay or co-insurance. But if the ultimate goal is like increased efficiency and improved clinical outcomes at a reduced cost, that does have to translate over to the insurance company, right? And at some level, like the only lever that the insurance company can pull on is either decreasing reimbursement or denying care, right? Like they can't do much else to reduce the how much you're spending on healthcare.
Right.
So it is only natural that we're over the last couple decades, we've seen the amount of reimbursement going down, and we're also seeing the amount of denials going up because there has not been much of a consistent effort on the PT OT side of things. And I'll say this as a practitioner and a business owner, like we have not been doing our part to make sure that the insurance companies are saving money, right? We're focused on getting the patient, pain free or whatever, but we're not worried about, is this the right number of visits? Can we cut visits out? Can we do whatever? And part of that is the skewed incentives in healthcare, fee for service model and all that. We can dive into that later, but it is almost a logical conclusion. Like we were going to find ourselves in the situation where we're at now, right? It's just part of how healthcare is paid for and who's paying for it. But so I guess kind of wrapping this up, what are some of the big tips? You've already given a lot about documenting actually what you see and you're thinking and the why, but what are kind of like the 2 or 3 main tips you'd give a clinician to avoid either a peer-to-peer review or an insurance denial? Because I'm assuming if
Sure.
you can document it well enough ahead of time, you can avoid some of those peer-to-peer calls down the line, right?
Correct. Correct. And I will, and that's kind of something, frankly, I've gotten into trouble for. And I'm kind of, scratching my head with one finger when I listen to that feedback from the powers that be, because at the end of the day, us as clinical insurance reviewers, our customer, if we're going that route, is the provider.
Yeah.
We are there to service them and be the arbiter agency of the insurance company to give them the yay or nay. And by the way, a peer-to-peer review is not the end all be all. There are always next steps. So please, providers, if you're on the phone with that insurance reviewer, then ask them that. What is the next step in this process? Because maybe some companies out there may not state that. Or read the facts that we send you. Please read that, because I know, I know it's another thing to do. And the administrative burden that this process puts on providers, I really want to scream I do scream sometimes, not on a podcast though. Please try to concisely read that to prepare yourself and ask what are the next steps. But as far as avoiding the peer-to-peer, be very clear about the impairment that you are treating, the functional loss, whether it's the patient goal, the patient wants to be able to do this, or you are seeing what maybe they're not doing as optimally as you would like to see them doing. So the impairment that you see, the functional ADL related loss that impairment is limiting, and what scope of interventions you and only you are doing that only a skilled provider can do, or the majority of which that supports that kind of sequence supports that patient being in your four walls instead of in their own four walls, and being extremely clear about what that is. As far as the data, again, we've talked about performance-based outcome tools versus questionnaire-based outcomes tools. I lean more towards, tell me what the patient showed you, whether it's a formal Bergtonetti, blah, 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 or it's, I had them sit and take off a pair of shoes, and this is what I saw. They didn't have sufficient external rotation. They had to, they had to rotate and side bend at their lumbar spine to get that movement. Great. That tells me something. And number 3, I would say please avoid the fluff. That whole impairment, functional loss, this is what I'm doing, should be enough for me to say yes. And then you repeat that process at eval and reeval to be able to say yes, or understand or identifying what those barriers to progress is. And just a couple disclaimers, do not, please, mi abuelita, she told me, do not confuse the issue with the emotion. I understand, and you are the one who's going to have to hear that patient bitch on the phone. And I understand, as someone who has had care for my son denied, and I've had to write a formal appeal and a grievance and but I know the system and I leverage what I know to get the results I need. So understand that that is a valid emotion, but it doesn't help solve the issue. So deal with the issue by all those tips we just outlined. Please do not catastrophize or threaten your reviewer. It doesn't get you anywhere. Like, it legit doesn't, because I understand, but I will just say to abusive callers, I'm sorry, I have to terminate this call. It seems we're not able to achieve a productive line of discourse.
Yeah.
And unfortunately,
there's nothing you can do once they hang up the phone.
I can't, right. And I want to help you. It's kind of like Jerry Maguire, help me help you. I'm dating myself by quoting that movie, but help me help you. So why, and only why, is continued skilled care necessary? Again, communicating your why. So listing, again, the problems are superfluous and ineffective documentation, missing the mark with your reader, and increasing friction points to care access. Like, we all don't want that. So again, you want to evaluate your documentation habits. And am I following that steps I outlined? You're including clear and objective information, keeping it simple, the meat, not the fat. I love me a good Wagyu steak. Like, don't give me a ribeye, please don't. So that all being said, I any other questions for me? This has been a supreme pleasure to just vent. It's like Festivus,
No, it's
but
been
no, not
great.
vent.
It's been
No.
wonderful. Where can people, because I know you've done a webinar on this in the past. I think you've got some stuff coming up about this. So
I do.
where can people connect with you about
Sure.
this, learn more about what you're doing, maybe see some of these webinars that you're coming out with?
Sure. So yes, I have done a couple webinars, my top 3 tips in avoiding insurance denials. I will be doing that again in early Q1 of 2024. So I am at the Nourished Nest PT on Instagram. You can also find me on LinkedIn. If you go to www.thenourishednestpt.com, it is a D. In there, you will see on my Work With Me or For Clinicians page. So that's kind of where it is.
Okay.
And I do work one-on-one with clinicians to kind of review documentation, give you my tips. I just finished up with one case that was extremely lengthy. But again, I'm trying to give you tips and tricks to kind of get that documentation reined in for your reader and just help you, using documentation as the best way you can advocate for your patients. Because it may be the only representation of the services that anybody reads. So I want to help you help your patients. Really, really, I do. So I appreciate your time, Rafi. Am I saying your name right after I
Yes,
said it?
You did. That's awesome.
Papa. All right, man. So, I appreciate it so much.
Yeah. Thanks. Have a good one. We'll link to everything in the show notes.
All right. Sounds good. Have a good one.
All righty. Well, I hope you enjoyed that conversation with Johanna talking about insurance review, denials, documentation, what needs to be in there, yada, yada, yada. Listening back now to the conversation, a few things I want to highlight that I don't think get talked about enough in the space that I spend a lot of my time in. I'm an occupational therapist. I work a lot with physical therapists, occupational therapists. I own a PT clinic. One of the things that does not get talked about in a productive way, in my opinion, is the idea of what healthcare insurance is, first of all, what it will and will not cover and what that means for us, the clinicians. I think the example I brought up in this conversation was how one commercial insurance company didn't cover sports medicine. They didn't cover physical or occupational therapy for sports medicine or sports injuries because to them, that wasn't a service that they were going to provide for their beneficiaries. So there's 2 big ideas there that I want to highlight. The first is that health insurance is not meant to or designed to cover absolutely everything. And I think that is a big misconception in the general public. And it's one of those, if you bring this topic up, you're almost looked at as, the bad words start flying, right? Like insurance should cover everything. And there's a lot of even public discourse and political discourse. I'm not going to get into any of those things. But the reality is that insurance, like health insurance, the contract between the payer and the patient is a contract where the patient is agreeing to pay the provider, the insurance company, a certain fee, a certain premium in order to share expenses or to have certain healthcare procedures covered or paid for by that insurance payer. So that contractual relationship is clearly defined in the user benefits manual. And if it's not, you can argue about whether or not maybe it's ethical or whether the insurance company might consider doing it in order to attract more customers and provide more value to the patients. But the reality is it is a contract, and the insurance provider is being very upfront about what they will and will not cover. So that means, one, we should not be upset about things not being covered after the fact, because you should know that going into it, right? The other thing is this idea about where the value is in healthcare, and the fact that commercial payer A won't pay for this service means that they don't consider it valuable. And we almost take it as clinicians as an affront, like, well, they need to see our value and pay us for those services, and the patient should not have to pay out of pocket. But the reality is, again, if you look at what insurance is supposed to be, it is supposed to be something that provides coverage for certain healthcare procedures, and it is a contractual relationship, hopefully freely entered into between the parties. And it is not necessarily a denunciation of the value being provided, the perceived value there. If a payer won't pay for a service, it just means that they don't cover it. Maybe it's too costly for them. Maybe their cash flow doesn't allow it, or for their business model and revenue model, they realize they can't afford to pay for this service, so they're just not going to offer it. It has nothing to do with whether or not they believe it's valuable or they think that it's evidence-based. Of course, there are some types of treatments and and services out there that are denied because they're not evidence-based, or they don't have the literature backing yet, or something like that. Healthcare technology, some of these up and coming digital health, for example, and telemedicine and all of that is one of those things that kind of fell under this blanket of, well, we don't have enough evidence yet to show that it's beneficial, so we're not going to cover it yet, but it's on the roadmap, right? That's a different thing entirely than saying, we as an insurance company, as the payer, just decided that we're not going to be in the sports medicine game, for example. That does not mean that they don't think it's valuable or that they don't think the treatment works. It just means that for their plan, for this business model of theirs, they're not going to cover it. So what that should mean to us as the clinicians, and probably to the patient as well, is that this is a service that maybe it is something that we've specialized in, we have certifications in. That should mean to us, like, okay, well, that just means that now my conversation, the relationship, the exchange here is now not going to be between me and this patient's insurance company. It's going to be between me and the patient. And if the patient finds it truly valuable, then they'll pay for it. And oftentimes, we as clinicians, I've said this for years, we as clinicians fall behind the blanket, or we use it as a wall, almost a barricade. If insurance pays for it, then we don't have to justify our value to the patient. And the reality is, as we move into a more consumer-driven, value-based healthcare landscape in the future, we as clinicians need to lean into those discussions and say, yeah, listen, your insurance won't pay for it because your plan doesn't cover it or whatever. We still know that it is valuable, and this is why it is valuable for your specific situation. These are the benefits you'll receive from it. This is the value our engagement in this treatment is going to provide for you. And being able to have those value discussions with patients is going to help us in the long run to become and really maintain relevancy as a healthcare profession, speaking primarily now to the rehab clinicians in there, but it's the same for any specialty. If your service is not covered by a patient's insurance plan, a perfect example here is allergists, right? And I just think about this because we have had to go to an allergist recently with one of my kids. Like, they know they're out of network, or dentists, like, they know they're out of network with everybody, and they don't care because they know what they are providing works and that it's valuable, and patients continue to pay. Why? Because it works and it's valuable. As clinicians, oftentimes we can fall into this, we just avoid having those value discussions, and we feel like we don't need to because insurance is paying. As we move into this world where more and more things are not going to be paid for by insurance companies, we need to be comfortable having those value discussions with patients. So that's just one of those side notes that I thought of listening to this episode, listening to this conversation, thinking it's worth having this conversation. So anyways, hopefully, again, you found the discussion valuable, especially if you're in the world of trying to document your services to get paid. So hopefully it was helpful to you in that regard. All right, I think that's all I've got this week. If you like the show, share it with somebody that you think would find it entertaining and valuable. I used to say leave us a rating and a review, but I think it's more impactful if you just share the message, right? So share it with somebody, colleague, friend, patient, whatever. It would help out a lot, and that's more valuable to me than the thumbs up or the 5-star ratings we have on iTunes, though we do have some of those as well. And if you are a innovative healthcare company, an organization, a service provider, or a technology or device company, and you are looking to develop an effective, succinct, and unique positioning strategy for your company, then check out the Positioning Alignment Workshop. Basically, what we do with this positioning alignment workshop, we help you answer the question, value to whom? So obviously, as we've discussed here, different stakeholders, they value things differently, and what they look for in a service or in a product is very much influenced by their position in the value chain, right? So Different stakeholders' perspectives will determine what they consider valuable and the outcomes they seek from healthcare services or devices or technology providers. So, by narrowing down that value to whom question, you have a clear idea of how your technology, your device, your software, or even your healthcare service is positioned to solve the problems faced by your targeted patient or healthcare stakeholder. If that is something you are interested in doing and working through, you can check out the Positioning Alignment Workshop. You can find more about that at positioning.rehabupracticesolutions.com. That's positioning.rehabpracticesolutions.com. Until the next time, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabupracticesolutions.com. We'll catch you on the next episode.